shared knowledge, okay, between these different pathologies, but important to focus in on how they're different. Okay, nerve compression syndromes. Okay, more so now we're moved down to the elbow, correct? Like I talked about last time, make sure you understand when you're talking about compression, which joint, which area of the body are we talking about. So ulnar nerve always seems to be the most important, right? So ulnar nerve compression, otherwise known as cubital tunnel syndrome. A lot of times you see the acronym CTS used interchangeably with carpal tunnel syndrome. So make sure you're focusing on which one you're talking about, which one the patient has, because cubital tunnel is elbow and carpal tunnel is wrist, correct? You guys know that already? We'll go through that a little bit more. So, ulnar nerve, cubital tunnel syndrome, second most common upper extremity nerve entrapment. What do you think the most common then is? Carpal tunnel, right? So, but important again, I keep telling you guys, is it the shoulder, the elbow, or the wrist, right? Which one are we talking about when it comes to compression, okay? You guys know this chart well, I believe. You understand where the ulnar nerve runs, you understand where the median nerve runs, and you understand where the radial nerve runs, okay? So the ulnar nerve, is that medial or lateral? Medial in relation to the elbow. So that'll come into play when we talk about some other injuries, okay? You remember how I was talking about how it's important to understand how many centimeters according to the textbooks that we're talking about. So a compression can occur with cubital tunnel syndrome anywhere from 10 centimeters proximal to 5 centimeters below the elbow, okay? But, again, is this medial or lateral? Medial, correct? Okay, so just make sure you understand when you're talking, when you read the vignettes, when you're talking about epicondylitis, for example, versus another pathology we're going to talk about later, don't get those confused. Zero in right away. Are we medial? Are we lateral? What are we talking about here? Okay? That way, going forward, you don't get confused. Okay? Because then, as it says there, radial nerve, right? That's radial tunnel syndrome. You remember how I said that lateral epicondylitis, because now we're lateral, correct? Lateral epicondylitis is 1 centimeter, it's at the epicondyle, or 1 centimeter distal, right? So if it's more distal than 1 centimeter, then you might be talking about radial tunnel syndrome, okay? And that's very commonly misdiagnosed as lateral epicondylitis. But you guys won't misdiagnose it because you'll understand that if you're talking about mid-forearm, right, that you're more concerned about radial tunnel versus lateral epicondylitis. Good to go? We good on that? Okay, we covered that before, okay? And what nerve is compressed there? Well, it is a radial nerve, but more importantly, the branches to the PIN, the posterior intraosseous nerve, okay? So we talked about AIN, right? That's the AOK, okay? The PIN is not something that's very commonly taught, but you can think about the PIN as a shooter, okay? If you take your fingers, everybody knows how to make your shooter, right? Shooter McGavin, right? Right? So shooter McGavin, so that's the ability to extend your index finger and your thumb as well, okay? So that's how you check the PIN. Okay, good to go. Shooter McGavin, right? And then medial nerve, pronator syndrome, muscular compression of the proximal forearm. This one is difficult to diagnose, okay, because it has very vague symptoms. But what nerve are we talking about? The median nerve, okay? So if we're talking about the median nerve, if you're talking about distal distributions, right, dermatomal, myotomal distributions, then you're talking about the median nerve distributions. And again, when you're talking about your sensation, there's very specific patterns of distributions that you guys learned well and did well on in the first block, correct? So now, again, we just keep building on knowledge. Cubital tunnel syndrome, how does it normally present? Most patients say it's like an achy pain, okay? And they'll say it's in the medial elbow. Again, don't get confused. We're in the medial elbow, right? So when we're talking about cubital tunnel syndrome, with those distributions very specifically of the ring and small finger numbness and tingling, okay? You guys know the difference between thenar and hypothenar, right? Okay, don't get those two confused. Go back and review if you don't understand. But this is hypothenar ache, okay? And if it's been present long enough, you'll actually see muscle wasting, right? And that's after several months of compression, according to your textbook, okay? But again, if you see that hypothenar atrophy, right, then you're talking about this has been present for quite some time, okay? Radial tunnel syndrome, right? Clinical symptoms for that, like lateral epicondylitis, but like I said before, it's more distal, right? That's usually 4 to 5 centimeters distal to the epicondyle, okay? Good to go? Okay, again, you see things are in bold gold, right? So I try to help you guys out. If you're going to study things, study them the way I kind of try to point out to you guys, okay? But this one, again, is very weird, right? Because is there actually any numbness and tingling? Usually not, okay? Can there be? Sure. But usually not. It's motor. The patients actually have motor issues, okay? Motor deficits, if you will, okay? Pronator syndrome, again, vague discomfort, numbness in the forearm, but this one is in the median nerve distribution, okay? So again, if you go backwards and look, radial tunnel really has no numbness and tingling, but pronator syndrome has numbness and tingling, but specifically in the median nerve distribution. Are we good? Okay, so what's important for physical exam? Complete upper extremity exam to include special testing. Tenell's test, Tenell's test, Tenell's test. You guys learned this already, right? Clin skills? Correct? Not yet? Okay. All right, good. All right, so Tenell's test, you basically tap lightly on the ulnar nerve, and it causes what? Pain and or paresthesias, okay? Pain can be, if you're tapping on the ulnar nerve, should they have pain at the medial epicondyle? Not necessarily, right? But they may have that numbness. So again, Tenell's, you see this picture up here? Right? You see the hammer? Okay? Can you use your finger as well? Sure. You're literally tapping on that guitar string, if you will, if you think of it that way. Don't twang it, right? The patient won't like that, okay? Don't be that provider, right? But you're tapping, okay? If you're tapping directly on the epicondyle, do you think you're getting the ulnar nerve? No. Again, you're trying to tap the nerve itself, so it's going to be more proximal to the epicondyle, okay? And you're literally, yes, just like gentleman is doing here, right? She's fanning herself for relief, okay? Is that you're tapping around that nerve. And we'll practice that in the lab, okay? Elbow flexion test, did you guys learn that one? The answer is no, and even if you did, you probably learned it wrong. But anyways, so what you do, basically, you do maximal flexion, okay? So what I tell patients, basically, arm up, okay? And I tell them to put their fingers behind their shoulders. Because if they're trying to do that, they're usually maximally flexing. Okay, do you think we have them maintain that position for upwards of 60 seconds or more? Yes. Again, you tell them, you say, hey, tell me what you feel and where you feel it and when you feel it, right? Because again, it's a timed evolution, so you're trying to get a sense, okay, if they go into that position and they have symptoms right away, that's probably an indicator of more significant pathology potentially, correct? Okay, so that's the elbow flexion test. The elbow compression test, well, you remember that guitar string you were twanging on? No, you were tapping, right? Now you're just compressing it. So you're literally just converting from tappy, 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 tap, right, like Happy Gilmore. You're converting from tappy, tap to compressing it, okay? And that compression, again, is over time, okay? So you're basically compressing it, and you're telling the patient again, tell me what you feel, when you feel it, and where you feel it. And you're trying to see what distribution they feel it in, correct? We talked about the ring and small finger, correct? Yes? Okay. All right, good. All right, so are we on the same page? I included these pictures. Allegedly, I did not change the slide, okay? Just to be like, hey, this is what we're talking about. So when you see it tomorrow, right, you're like, oh, okay, I kind of have a sense of this. Now I just got to practice it, okay? Good to go? All right, you're welcome. Diagnostics, here we go again. So this is a compression, right? It's maybe kind of vague. You're like, is this peripheral neuropathy? Like Dr. DeBoer was talking about, patients with diabetes get these peripheral neuropathies, right? It's more due to that metabolic syndrome, et cetera. So how do you differentiate? Electromyography, neuroconduction studies, okay? In this case, your book does highlight that a reduction in that velocity of 30% or greater suggests ulnar nerve compression. Do you think that's a reduction in the velocities from the elbow to the wrist? Or from the shoulder to the elbow? Elbow to the wrist, correct? That's what we're talking about, okay? So we're trying to see that compression as it affects the upper extremity distally, okay? Good. So outcomes of disease, obviously if it hurts, they'll stop doing it. They can get stiffness, but also they can get decreased strength and sensation over time, because again, if those nerves are compressed long enough, then you have motor deficits and or neurologic deficits, okay? Or paresthesias versus numbness, and we talked about in block 1 how numbness is bad, right? Numbness and tingling is one thing, but if you progress to numbness or the inability to feel, right? So a lack of sensation, then that's a sign of more progressive symptomology, okay? Stiffness, 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 the enemy orthopedics, always fighting it, okay? Good to go? But again, patients will report that they can't do certain activities because it causes that numbness and tingling, therefore they'll stop doing those activities and you may see some stiffness. Okay, non-operative treatment, okay? We'll get right to it. You guys know all the non-op stuff, and it says rice strapping. Okay, can you do some strapping with this? Sure. But more so we do splinting, okay? Have I ever seen a patient in this posture, if you will? Never, okay? But it's something your textbook talks about, okay? If you're out in the field, downrange, you need to do something like this, okay, good to go. But occupational therapy, I'll talk to you guys about how occupational therapy, they do things from the elbow down, right, very commonly, and that they're very good about fashioning custom splints. So they can fashion custom splints to put the patient in this position. So they don't walk around looking like they just robbed the Bed Bath & Beyond, okay? All right, good to go. So steroid injections, not recommended. We talked about it already, right? That guitar string doesn't like you twanging on it. Well, it definitely won't like a needle, okay? So don't do that. You know, because forget about tendon, weakening of the tendon. You can weaken the nerve or transect it, and then you will be having a bad day. And more importantly, the patient won't like it, and they'll be having a bad day, okay? So this is a compression, right? Can we decompress? Absolutely. That is the operative treatment for it. Okay, nerve decompression surgery, it's multifactorial. A lot of times, like I said, we get the EMG, the reconduction study, get an idea, but also get an idea of whether or not that ulnar nerve is stable in its normal anatomic station, if you will, its position. Because can they have a subluxation of the ulnar nerve as they go from extension to flexion as well? Yes, so not only do you have a compression, but they have subluxation. So that's why it says plus or minus transposition. Transposition is literally taking it from where it is and putting it somewhere else to be more stable. Are we good with that definition? Okay. All right, see that surgery there? That's the Lord's work, right? So the blue arrow and the white assistance device, right? So people use that as a tourniquet, right? So that is meant to get the nerve out of the way. So we identify the nerve, move it out of the way, do what we got to do, and make sure we're always cautious and making sure that there's no chance of badness to occur when we're working in and around the ulnar nerve. Good to go? Okay, that's your surgical definition. Okay, adverse outcomes of treatment. Obviously, if you put a splint on that's improperly measured, sized, and applied, it can cause compression itself, so you may worsen symptoms, okay? And then we always warn patients, and I tell you this all the time, we warn patients about every orthopedic surgery, right? And tell them, hey, if you're having pain, we may take some of that away, but if 100% pain relief, a lot of times is not realistic, okay? But in this case, you were talking about nerve compression, so we're talking about paresthesias, right? Numbness and tingling, okay? So we tell the patient, our hope is that when we do these surgeries, if we have to move the nerve and put it somewhere else especially, that you'll stop having these symptoms. But do they sometimes have residual symptoms? Yes, right? But the whole thing is that we try to improve those symptoms, meaning they have an improved quality of life, okay? So red flags, substantial progressive weakness. Like I said before, if you see that hypothenar atrophy, that's a sign of significant issues, right? They have burning, searing pain, not crypts, but their pain is like significant from these paresthesias. That's bad. So increasing numbness, bad, right? And remember, work, play, sleep. If that affects one of those three components, the patients will more than likely present and want further treatment, which ends up being surgical if you guys have done all the proper non-operative care and you've gotten the EMG, the nerve conduction study, all that stuff. So going back to the nerve conduction study real quick, is it valuable to get a nerve conduction study only on one side? No, always get bilateral, okay? When I was in Japan, you ordered it, they got it off base, right? So they always came back with unilateral, one side. So you have to be specific in your study, okay? depending on where you're stationed especially. Distal bicep tendon rupture, we've already covered proximal biceps tendon rupture, right? So this is the distal component of the biceps tendon, and this is closer to the elbow. That's why it goes kind of side by side with orthopression syndromes, okay? In discussion only though, okay? Uncommon, right? Less than 5% of biceps tendon ruptures, okay? Not as common as proximal biceps tendon ruptures that we already discussed, okay? So, but it can cause greater weakness than the proximal biceps tendon tears. So remember I told you that with the proximal biceps tendon tears, you can let it go because it wasn't as significant of weakness. With this though, it's the opposite, right? So distal biceps tendon ruptures, for the most part, we try to encourage patients to get operative care for because it'll affect their function, okay? So what's that anatomy again? I gave you guys that supplemental slide, right? It's at the radial tuberosity, right? So a lot of times they are complete. Sometimes they can be incomplete, partial, right? We understand that's the same terminology, right now? By now, I hope you do, right? So men older than 40 years old with pre-existing tendon degeneration, so they may have a preceding history of distal biceps tendonitis, right? Not proximal biceps tendonitis, but distal. And then they go on to pop, okay? Because we understand this is a rupture. It's a complete disruption, correct? But it does say you can have partials, and we'll talk about that. Partials is more like a mixed clinical picture when you're doing your physical exam, okay? Everybody understands this picture here, this illustrations here, all right? We've kind of been through this already with the proximal, okay? So, I did not add that red arrow. It just magically appeared. But, having said that, if the attachment point is distal, where is the muscle belly going to go? Proximal, right? So that's called a reverse Popeye, right? Everybody, if you didn't know who Popeye was, you looked it up, right? I had one student, didn't know. That's cool. I don't know what kind of childhood they had, but, you know, if you don't know, you don't know. But it's a reverse, this is a reverse Popeye deformity, okay? So the muscle belly goes proximal. Do you think if they flex against resistance, right, what I'm demonstrating right now, that deformity and that motion of the muscle belly is going to be accentuated proximally? Yes, right, because that's the whole thing, right? So you may see it sitting there, but there's no resistance there that I can see. But if you go ahead and make it resist, why you would do that, I don't know. But it's in your book, so I tell you, okay? Severe pain, few hours followed by chronic dull ache, worse by lifting activities. Well, I already kind of prefaced it that they're going to have issues, right? They're going to have issues with both supination and flexion. Okay, and we'll get to that here shortly. Any questions about how this is different than proximal biceps tendon ruptures? No? Not yet? Okay. So where are they going to have the tenderness? Well, they're going to have the tenderness distally, right? That's in the cubital fossa. Okay? And ecchymosis, again, early on, like I mentioned before, the ecchymosis can kind of travel, right? But early on, you should see the ecchymosis at the AC fossa, right? At the cubital fossa, or there on or about the elbow. You should not see the ecchymosis proximally. Everybody knows gravity goes down, right? Not up. Okay, unless the patient's walking around like this, right? Okay, maybe, but not usually, okay? So just understand that concept, okay? We talked about biceps flexion. Hook test. Hook test is something I will tell you, you will have to have practice at this to be good at it, okay? Do you guys remember from A&P? Ooh, everyone just blacked out, right? That there's the Lacertus fibrosis. Does anybody remember that? No, okay. All right, so we understand that the distal biceps inserts at the radial tuberosity. Well, there's other things that insert not on the radial side, but on the ulnar side. That's called the Lacertus fibrosis. It kind of spans there too, kind of goes across, right? But it can confuse you a little bit because you have to be very focused on where you're doing the hook test, okay? So again, when you're doing that hook test, are you trying to hook that tendon as it inserts in the radial tuberosity? The answer is always yes, correct? Unless it's no. But in this case, you're trying to hook it, and you're trying to feel it as it inserts in the radial tuberosity. Maybe not specifically as it goes all the way down. If you're going that deep, it might be a little too aggressive, right? But you're trying to hook it and see, right? So, when it comes to hooking it, you can either hook it or not hook it. So do you think hooking it or not hooking it? So hooking it is a negative test, right? Not being able to hook it is a positive test. That means it's disrupted. Are we good? Okay, I allegedly added this picture here just to show you that's a really good picture of the hook. They got the finger deep in there. Okay, they're hooking it, right? They're good to go. All right, imaging-wise, this is an area with the distal biceps where bless you. You made my day. Where we oftentimes will get radiographs, right? And why do we get radiographs? Well, because you can see. Remember I told you that's a strong attachment point, correct? So you can see there where it's supposed to insert its radiotuberosity. There at the radiotuberosity, some bone got pulled off. Well, do you think that tendon pulled bone off as it ruptured or pulled away? Yes, that's what you're looking for, okay? So important to get that view, okay? Very oftentimes it'll be the lateral view, but you're going to get a complete series. MRIs, always get MRIs for these, okay? COVID. So because MRIs will tell you like where, if it's disrupted, but not only that, remember we talked about this concept of retraction? It's under a lot of tension, right? So as soon as it avulses or ruptures off its attachment point, it's going to want to pull back, right? So you want to get a better sense of where it was, where it's supposed to be, and now currently where it is. Okay, the arrows there tells you, okay, that something's abnormal there, something's abnormal there. The other thing the MRI does, if you do a hook test and you're like, I don't know, I still kind of feel like I feel an attachment point there. Is it the Lycurgus fibrosis? Is it, that's throwing me off? You can get a better sense of that because you're like, oh, no. It's completely detached, okay? So what it says there is avulsion of the tendon versus rupture at the musculotendinous junction. What that means is just because, we always talk about the distal biceps and as it inserts in the radiotuberosity, is it possible for it to rupture or tear more proximally on into the musculotendinous junction? It is, okay? And I will tell you this is all you really need to know. The treatment for that is different, right? Because you're not trying to anchor the tendon as it inserts. It's still inserted. Now you're going to do a repair potentially of more proximally, of closer to the muscle belly. Does that make sense to you guys? Okay, good. But it says usually necessary to confirm diagnosis. Again, focusing on the word confirm, right? You do your physical exam, the history's there, okay? Very commonly, I think I described to you already, bicep tendon ruptures, especially in the younger population, tends to be feats of wonder and glory, right? I talked to you guys about the Iron Cross Challenge, right? So, so the history will be there. I went to do a bicep curl, right? They got on the preacher bench, right? They were into the preacher curl, and they went for deceleration and felt a pop. Okay, it'll be some kind of history where it was all distal, it was elbow, not proximal, shoulder. Good to go? So your history is important, guys. Okay? All right. Loss of flexion strength, I don't even know what I was saying there. Loss of flexion strength is 15%. Okay, flexion strength 15%. Okay, good to go. But the loss of forearm supination is how much? 50. That's significant, and it's never coming back. You will never. The tendon will not magically travel distally. It'll retract. It'll come more proximally, right? And they'll just have that permanent loss of 50%. Does that sound significant? It does, right? These guys are back here, showing off between classes. If they're out there trying to do certain activities, right? They won't be able to do those. They just won't look as sexy and cool, right? Because they just can't do certain things. Right, so 50% is important. Okay, so distal bicep tendon ruptures, 100%. Get the MRI, send them acutely. Call me, right? Don't worry, we're interested. Okay, because that's good surgery. Okay, non-operative. All right, these are older patients. Okay, so when do we say, well, yeah, you ruptured distal biceps? Normally you would say, okay, we're going to fix it, but you're older, right? Older than me. Okay, just older, less active. I'm still sort of active, okay? Sedentary, right? So they ruptured it however they ruptured it, but they're just not as active, okay? Again, did I tell you that arm dominance when it comes to upper extremity injuries is important? Yes. If you call me on the phone, you're talking about some injury to the shoulder, elbow, wrist, hand, I'm going to ask you, are they right or left hand dominant? Because that has some role in it, right? Some play in it, okay? Operative, when do we want to get to these? We already talked about the concept that when retraction starts, right, the muscle belly starts pulling proximally. That's what occurs, correct? Reverse pop-eye deformity? Okay, yes, okay. That it starts to want to heal in and scar in wherever it now sits. So we want to get to that pretty quick, usually within 2 weeks. Honestly, we try to get to it as soon as possible, but within 2 weeks is preferable, okay? Repair versus reconstruction. Repair, I told you guys already. You're taking what God gave the patient, and you're going end to end, and you're repairing it, okay? Reconstruction means it no longer gets to where it needs to go, or it needs augmentation to make it a strong unit again. Therefore, you reconstruct it. So reconstruction can be, for example, using a tendon from a cadaver to now recreate that relationship, especially at the insertion. Good to go? Okay. All right, so this picture showing there, you see how there's a deep dive. You put drill holes and you put those anchors into there, and you do a nice big suture bundle and pull all that through and tack it down. Try to recreate that tension again, right? Get rid of that reverse pop-eye deformity, correct? Yes, that's the goal. So do you think if we're poking holes, we're making incisions and stuff, remember we talked about the AIN and the PIN around the elbow, right? Do you think those are things we have to identify and protect? Yes, because you're not medial. You are directly anterior and potentially posterior. So maybe not the ulnar nerve necessarily, but definitely the AIN and PIN. Good to go? So when you call me on the phone, guys, and you say you think the patient has a distal bicep tendon rupture, I did a hook test, positive. There's no insertion, I believe. Right? I got the radiographs, I see that avulsion. Okay, good to go. You think I'm going to ask you about the Shooter-McGavin, right, and the AOK? Yes, I'm going to ask you your neurologic findings too, just to make sure this wasn't a nerve that was involved. Good to go? Okay? Because, especially if there's a fracture involved as well. Okay? All right, so here, adverse outcomes of treatment, just real quick, which nerves are we concerned about mainly? Radial nerve, again, we started talking about those branches, as we get into AIN, PIN, but the radial nerve is the one. Okay, so on a board test question, they'll pull it back a little bit. Just say, overall, what's the major nerve we're concerned about? In this case, radial nerve. Okay, so can everybody see the radial nerve? Can my button work? There we go. Radial nerve right there, it's labeled, right? And see how it branches distally to PIN? That's what I was talking about. And you see where that button is, right? You see that button right there? It's called a cortical button. Everybody knows what a cortice is, right, as well? Okay. So do you think that button is the thing that comes out this side over here? At the bottom here? Yes. So that's what this picture is denoting, is that you're working real close in that area. So you want to know if there's any pre-existing radial nerve pathology or presentation or symptoms to understand, the issues you may have with the surgery, okay? Infection's always a risk, okay? It's a risk with any surgery, right? Constant on that. So can they have a residual decreased strength? Yes. Maybe they don't get 100% back is what I'm saying. Do we tell the patient they're going to get 100% back? You guys have already surmised we don't tell the patient we're going to do 100% of anything, right? You got to tell them, hey, you may still have some residual loss of flexion and forearm supination, but you won't have 50%. Good to go? Okay. Heterotropic ossification, have you guys covered that concept yet? Bless you. He said that. All right, HO. Have you guys covered HO yet? Okay, heterotropic ossification. So a heterotropic ossification is basically where you make bone where it shouldn't be. Okay? If you have little fragments and muscular injuries, right, do you form blood clots in that area? Hematomas, things like that? Do you have residual scarring that occurs? Sure. And if that residual, those residual sequelae of the pathology decide to become calcified, then you get heterotropic ossification. Ossification being the working term there, right? Everybody understands that ossification is the conversion of something into bone. Okay? Makes sense? So is that very common with this? It is common. Okay? So if a patient comes back and says, surgery was 100%, I got maybe like a loss of 5 pounds on my curls, right? Good to go, but then you get a radiograph and you see that ossification. Are you supposed to be able to see soft tissues on an X-ray? No, but if it becomes HO, it has not ossified, therefore you will see it. Okay? Good to go. Re-rupture, always, always, always an option. right, for the patient, especially if they're non-compliant with both the weight restrictions, the motion restrictions, etc. Okay, but it's always possible. Okay, we always say that the second surgery is never good as the first, but that's just, all bets are off. You got to get a new MRI and see what's going on. But re-rupture is possible. Chronic pain, sure. Any patient can have residual pain, right? Any questions about the adverse outcomes even of treatment? This is of treatment, right? Even if we treat them, they could get this stuff. Okay? So again, the way you guys should start learning this stuff is that you have to understand that just because we treat them doesn't mean they're going to be 100% compared to pre-injury levels. Good to go? There are risks. Okay? Any questions about distal bicep tendon rupture? Okay? No? I know I went quickly through that, but we already covered proximal. So now we just got to go to the other end and put together the concepts. Okay? Ulnar collateral ligament tear. You guys will spend some time on this, I hope. Okay? Because when I'm talking about ulnar collateral ligament tear, right, is that on the medial side or lateral side? Medial side, correct. So is it sometimes called the medial collateral ligament or the medial ulnar collateral ligament of the elbow? Yes. So is that done to confuse you? Probably, right? Because medicine has to be complicated, right? But we're talking about the same things. But when it comes to this, not only is the anatomy important, but it's important to understand that when I'm covering it now, I'm covering it in relation to adult injuries. And I'll confuse you a little bit here shortly, okay? But ulnar collateral ligament tears, so let's think about this. You guys know what valgus and varus stress is, right? Okay? So if it goes outwards, is it going to stress the medial components? Yes. Okay. Because that's what it says, right? So that's a valgus stress. You see the L I'm making? Does everybody see the L? Okay. Does anybody not see the L? Take my humerus as one part, right? One line, right? Take my forearm as the other line, and then I'm going out, and that makes an L. Okay? Outward facing L, if you will. Okay? Good to go? So that's the motion that the injury is normally going to occur. So is it important to understand what position the patient's arm was in when they sustained this injury? Yes, because it'll give you some clue as to maybe what structures are involved. Also, do you think when we get to physical exam that there's there's a valgus and a varus stress of the elbow? Yes, so you would expect to have laxity in the valgus stress and not the varus stress of the elbow. Okay, good to go? Okay. Uncommon and rarely result in instability or disability. How does that make sense, right? So the uncommon part, okay, it's uncommon. So there are certain populations where it's common in though. Do you think it's throwing athletes? Yes, we'll get into that, right? But why doesn't it cause significant instability a lot of times? Because there's other structures that provide inherent stability to the elbow. Okay? So in order for an elbow to be grossly unstable, a lot of other structures have to also be involved. But if it's an isolated ulnar collateral ligament injury, gross instability, meaning a lot of instability, right? Like loose, right? Is not common. So you may do that valgus stress, and do you compare it to the other side? Yeah. Remember, you're looking for millimeters, right? Millimeters, 5 to 10 millimeters, etc. So you have an increase in that valgus translation, right? That lateral translation compared to the contralateral side. Okay. So where do you commonly see the instability if it's present, though? Again, it's or disability even. And disability is not what you think, right? This isn't the ADA thing. This is just saying the patient can't do something, right? Again, throwers, what is it, javelin? Yeah, javelin throwers, right? I don't know that I've ever treated a javelin thrower, but sure, right? But baseball, sure, most certainly, right? Especially when we cover like NCAA teams. Patients would come in and say, I have medial elbow pain, I was throwing, I felt a pop, and now I've had subjective weakness, and can they have some numbness and tingling in that area? Yes, right? So don't let that throw you off to your test, right? Felt a pop. Nerve paresthesias, we just talked about this. Does it get worse when they throw? Yes, it does, okay? Can they have swelling ecchymosis? Yeah, but remember, this is one isolated ligament, so it may not be as prominent as you think. It's not going to be like a distal bicep tendon rupture, right, necessarily. in your mind, you remember that picture. I can show it if we need to. But the swelling may be minimal or it may be very localized. Everybody knows what I mean by localized, right? Just right there on or about the medial elbow. Okay? There you go. Okay? So then it says often absent. Again, it may or may not be there. Okay? Loss of terminal extension. All right, here we go. So you tell the patient to do what? You guys know your range of motion of the elbow, correct? Full extension, is that 0? Yes. Yes, the answer is yes. Okay, that's 0. Okay. So then you have, again, I tell them to take their fingertips, try to touch the back of their shoulder to get a sense of the reflection. Okay. Do some people, some patients with Ambry, for example, have hyperlaxity and they go past 0 and going down, right? Yes, they do. Okay, so again, it's important to understand when we're talking about loss of terminal extension, that we're talking about the ability to get to 0. Good to go? Okay, that's what we're talking about. So that's when they're going to complain about it. Okay. The tenderness again there can again, if they have some nerve involvement, right? That guitar string got twanged, if you will, right? Can you have a positive Tinel sign? Yes. But what makes this different? You have laxity, right? Is that a ligament? It's a ligament. So then you have the laxity as well. So you've gone into old UCL territory. Okay? So again, this is why if you don't do a good physical exam, guys, like it says there, you have inaccurate diagnosis of neuritis, right? Nerve involvement. And meaning it's primary nerve etiology and not the UCL injury. Okay? And will they have pain with valgus stress testing? Sure. Right? But is that necessarily what you're doing the stressing for? Not necessarily. So again, remember what you're testing for. You're testing for laxity. If they report pain, you can document that, but you should report the laxity compared to the contralateral side. Radiographs, why would you get radiographs? It's like, oh, this is all soft tissue. Well, because, do you think that as the UCL inserts distally, that if it pulls off, right, at the insertion point, it can pull a little piece of bone off? Yeah, same concept as the distal bicep tendon rupture, right? So you're looking for other pathology, okay? And do you think if it's been ongoing long enough, and as they're throwing, nobody here's a baseball player that said, right? But you guys know that baseball players throw a lot, right? So over time, can they have chronic fracturing in that area? Yeah, you have little what's called loose bodies, right? And the term I use with you guys is chiclets. You get an X-ray and you're like, that looks like a bunch of chiclets. So everybody knows what chiclets are? Okay. All right, good. If you don't, see me after. All right, so MRI arthrogram, okay, is this intra-articular pathology? 50-50, 80-20. Is the UCL intra-articular? Yes. Okay? Yes. Meaning that it causes, if it's ruptured, it can cause intra-articular instability. Okay? So if it can, would then an MRI arthrogram be the best thing to diagnose it? Because an arthrogram, you guys understand, it's not the contrast where you lay them down, you poke them 1,000 times, finally get a line, and run the dye. An arthrogram is where you inject the dye into the joint space itself. Good to go? So it can tell you a lot of information. Okay? Remember how I told you there's a bunch of structures in or around the elbow that's not just the UCL that provides stability of the elbow as well? Yes, you do remember that, right? As you're studying the form. So the thing about this MRI arthrogram is they can help you discern between the difference between the intra-articular components and the extra-articular components. Because you're still getting an MRI as well, right? The difference is you're adding the arthrogram component to it. Do you understand that concept? Okay, good. So if it goes on long enough, obviously they can have instability, so they can have chronic instability. Disability, again, they're not disabled, they don't rate ADA, VA compensation or anything like that necessarily. That's a slippery slope. But meaning they can't do things. Work, play, sleep, okay? Chronic stiffness, did they have a loss of terminal extension with this? So if they have a loss of terminal extension for a long enough period of time and they can't get full range of motion, is that called stiffness? Yes. Is that the end of orthopedic? Absolutely 100%. And again, that gets back to that decreased range of motion. Okay? So non-operative care initially, right? Especially when you're still trying to figure things out, you tell them, you got to stop throwing. Okay? no throwing motion. You put them on restriction, okay, if it's a baseball player. If it's a javelin thrower, no javelins. If it's a grenade thrower, I'll try to use an example here. If they're throwing grenades, no grenade throwing, right? Whatever it is they're doing, get them to stop doing it, right, because this is going to further complicate the issue. Why do you think we don't inject that area? Is it medial? It is medial, right? Do you still want to go into the nerve and transect it or make it angry? No, you still don't want to do that, right? So don't do it in this case either, okay? Good to go. Surgical reconstruction. Has anybody heard the term Tommy John surgery? Famous baseball player, et cetera, okay? Yeah. So Tommy John surgery is complicated. It's almost likened to, remember I told you the AC, comboclavicular joint surgeries are kind of like a mixed bag. You can do a lot of soft tissue, you can do a little bit of bony stuff. But basically what they're showing you here is that there's a nice little architecture that's created with a bunch of tunnels there, okay, going through and up and around, and trying to pull things down. So Tommy John is a very specific surgery that's, again, takes multiple techniques and tries to incorporate those together to create stability of the elbow. Okay? Good to go? That's just an example of a surgery. Are there other surgeries that are done for this? Sure, especially if there's a fracture there. Okay? But Tommy John is associated with UCL injuries. Good to go? Okay. Adverse outcomes of treatment. Which nerve was potentially affected? Ulnar nerve. It's in old gold. You gotta know that. Okay? Don't get that confused with the other nerve, which is which one? The radial nerve. Okay? So don't get those two confused. Zero in on those. Okay? UCL, ulnar nerve. All right? Infection, always. Infection is always a concern, right? Persistent pain, yes. Right? Even after surgery, like I keep saying, the patient gets stability because that's the goal of the surgery, correct? But they still have residual pain. Well, guess what? We fixed the instability, which was our main goal, but you still have residual pain. Okay? Good to go. Stiffness, always possible. Especially more so if they're not compliant with physical therapy. Okay? So I would tell you that, if you have a concern for, like, say, a partial UCL tear or a chronic UCL tear that's not significant on exam, right, and the MRI doesn't show, you'll do a lot of non-surgical management, right? And that's in most patient populations. So that's the number one answer, is you'll do all the conservative care. But the number two answer is if they're a high-level athlete, okay, and I told you my thoughts on this, correct? There are certain communities in the military, you're high-level athletes, right? There just are, based on what you have to do. Then the consideration for referral comes faster. Okay, good to go? Any questions about that concept? No? Go. All right, I'm going to push through this, and then we'll take a break. Nursemaid's elbow. Has anybody heard this term before? All right, this is not handmaiden's elbow. Please do not call it that. That denotes something completely different. Okay, so this is nursemaid's elbow. Okay, so has anybody here had a nursemaid? Are you that rich? Were you that rich growing up? No. Who was that rich? Who had a nursemaid? Okay, all right. So if I picked on Mr. Pavone and said, let's go for a walk, sir. Okay, and I pulled him along, just like you see parents pulling little kids in the playground, right? And I pull hard enough, let's say the little kid, not him, he's sensitive, right? That's usually the mechanism of injury, okay? It's a traction injury, the pull, the traction, the pulling away from the elbow, forcefully pulling the radius away from the elbow joint, okay? So what are we talking about? The radial head gets pulled out of the annular ligament. Okay, the annular ligament, right, goes across. It's like, kind of, if you liken it to the transverse ligament spanning the bicipital groove, right? This is a transverse ligament, but it's specifically called the annular ligament. So that provides restraint and keeps the radial head in the proper, I would say, or the preferred anatomical alignment. So is that considered a subluxation? It is. Is it possible to dislocate your radial head? It is. But in this case, we're focusing in on a subluxation. So it's kind of out, but not out of the way. Does that make sense? We talked about the difference between subluxation and dislocation already. Okay? So that's what we're talking about here. It's associated with increased ligamentous laxity. What does that mean? The patient has increased ligamentous laxity. Are kids loosey-goosey just as a rule, though? Yeah, most kids are, right? So that's why you see this in certain populations of pediatrics, the most common. We'll talk about that, okay? But again, if they already have increased ligamentous laxity due to other concerns, Ehlers Danlos, whatever, right, then they can be more predisposed to this as well. Okay, that's all that's saying. Okay, not as important to focus in on. But what's the age group it's most common in? 5-year-old. ER calls me on the phone, says I got a 5-year-old. I'm like, okay, how many months? I just got to mess with them. But it's like a 5 or 6 years old, right? Right. So I'd say, okay, all right, cool. And they were on the monkey bars, right? And they jumped, right? They jumped away, and they grab onto the bar. As you go down, gravity still takes over, right? It causes that traction. So it doesn't have to be the nursemaid, right? Mr. Ballone's nursemaid, notwithstanding, right? I'm just saying, it can be a traction-related injury too. Nursemaid is just a way to remember it, okay? Good to go? But the injury's there, the mechanism's there, okay? Sharp axial pull, okay? And so what are you gonna find? Elbow extended, forearm pronated. That's the normally the position that they would sustain an injury in. Okay, is the child going to be able to tell you that the arm was in that position? Not necessarily, right? But what the child will be able to, what you will be able to witness, and I provided a picture allegedly, is that the child is holding their arm in a certain position and what? Doesn't want to move it. Well, refuses to, for example, I got my little tricks, right? We know about the jingle jangle that certain people have on their stethoscopes to, like, you know, pediatricians have, you know, little things to get the patients to pay attention. Well, like for me, my trick is the ER normally has ice cream pops, okay, the frozen bars, little pops, right? And I'll say, hey, you want this? And they refuse to go after it. It's like a natural, innate instinct for 5-year-olds to want to get to sugar, okay? So that might be a trick to do that, okay? So little things like that. But they refuse to use the arm, and they react and cry when you try to get near them, right? You're the big, bad, scary provider, right? So a lot of times I sit down, get down to their level, try to reassure them, and things like that, then offer them candy like a creepy person, okay? Right? So you'll find them with their arm held to their side, elbow flexed, and forearm pronated. Is this forearm pronation the way I'm holding it? So this is the position you're going to find them in, right? This is what I'm talking about, like this. And they'll have their other hand like this. Everybody sees it? Who's taking pictures? All right, I'll take pictures of it, okay, without my consent. All right, so, but that's the position you're going to find them in. So there you go. There's the picture that allegedly got provided legally. Okay? So when you examine them, because you will still examine them, they will still scream. But they'll scream more or be more uncomfortable when you're palpating the radial head, right? Because it's a subluxation of the radial head. So that's why you have the maximal tenderness, okay? And then when you try to take their arm and put them into supination, they will not like it, okay? Continue offering candy at that point, it doesn't matter because now the deed is done, okay? They are uncomfortable, they don't trust you for anything. So now you got to take over, okay? But before you take over and do your heroic measures, right? You want to do a neurovascular check, okay? All right, so does the patient, if they're sitting there like this, can you tell them to do the OK and the shooter and the finger scissors and the rock and the paper? You can tell them to do that. That shouldn't cause them too much pain, right? All right, so you can still ask them to do those things, right? Most people know those things, right? Rock, paper, scissors, shooter, OK. Okay, so then you've got your neurovascular checks in. Now you move on to getting your radiographs, right? Because you want to see, okay, they said they jumped off a monkey bar, but they say that Mr. Pavone went on a running start and pulled their arm out of socket, okay? But you need to get some x-rays because there was some level of trauma involved. There was some mechanism there. You would never do that, I know. But, so what's that view that we talked about? If you want to get a good view of the radial head, the radial head view, but it's also called the Greenspan view, okay? GreenSpan. Whew, that's pretty good. All right, so Greenspan view it's also called, okay? If you're like, I don't know, is it out, is it not out? Are you going to get comparison views? Yes, get them, okay? Does that radius, proximal radius, look like it's not where it's supposed to be? After you've looked at about 100 x-rays, you will agree that it does not. And, oh, by the way, somebody, I don't know who, put a red arrow saying that it's not where it's supposed to be. Correct? So that's not right then. That's not the correct orientation. Okay? All right. So do you think that you found the patient in pronation, correct? You found them in pronation. So do you think you're going to want to reverse the position that they're holding their arm in? The answer is yes, even in this case, right? So the heroic measure, and that's what this picture was there. I think it was there originally. But you want to basically put firm pressure, so you, with your thumb, right, of one hand, right, depends on which arm it is, right? So if it's right arm, I use my left hand, think about this, right, to put on the radial head. And then with my right hand, I try to put them into supination. So I'm reversing the position I found them in. Am I trying to push that radial head back where it should be because it's sublux from the annular ligament? That's what you're doing. So it doesn't have to be like a forceful thing, right? It's not like you're doing this traumatic event. But once you've started the exam, right, there's kids just going screaming. So you just got to do it. Just do it, right? Because I'll tell you, you push on the radial head, you supinate them, you feel that very satisfying pop, right? You want your thumb there because you got to feel the pop. Right? You're not going to hear that pop necessarily. Sometimes you do, but you feel it, right? Do you think immediately then the patient's like, whoop, and then they want to reach for your candy, right? And then they want to like reach for your pop, or whatever, right? Your frozen pop. Yes, it's like immediate. It's like an immediate thing. Oh, now I have full range of motion. Right? You document your full extension, your full flexion, your full pronation, your full supination, all that stuff, right? So, but say you can't get it, right? You can't get it just from doing the radial head push and the supination, then you flex them as well. Okay? Then you flex them as well. So it's a two-part maneuver. You don't have to necessarily do the flexion. I can tell you something. Usually when I get called about this, I'm in the middle of something else. Or so, because they usually, when do kids get seen in the ER? What's the highest amount of time they get seen in the ER?
Bedtime.
Usually about 1,600 to about 2,000. Why is that? That's when everybody gets out of school, right? So the school nurse is like, oh, it's probably fine. And Mr. Pavone, he's just a mean guy, right? He did something to that patient, but he's probably fine, right? But that's usually when people present, right? That's a busy time of the day where we're all driving home and stuff like that. So by the time I come in, I just want to get it over with. So what do I mean by that? I mean that usually I go for the radial head push with my thumb, the supination, but also just go for the flexion. But if at any point you feel that pop, you're done, right? But if you do both of those techniques together, it's pretty successful, okay? Because you want them to know right away too, and this is going beyond, stop listening if you choose, but you want them to know, if you can't get it with that maneuver, do you think there's a maneuver where we now rotate them back into pronation and do the same thing? There is. So you want to know right away, do I have to do that other maneuver versus this primary maneuver, which is what I'm teaching you, and which is what's testable. Okay? I will tell you from my experience, I've never had to do the other maneuver, but it's probably because I'm aggressive, right? And I just want to get it back in there, okay? So, but that's the reason I tell you have to be decisive, right? When you're going for it, you walk up to the patient, right? Hopefully you already have x-rays, right? Don't get scared. You already have your x-rays, right? So you're like, okay, there's a tender there, A-OK, push, rock, paper, scissors, shooter, McGavin, and then you say, Mom, this is going to be momentary, but unpleasant. You do your maneuver, and all of a sudden the patient's like, oh my God, I feel better, right? You're good. You can walk away now, high five, make sure they have your billing and your collectibles information so you can get paid, and you will go about your life, okay? Good to go? All right, let's take a break. Yeah, I would. Oh, sorry. Good question. Pull the kids on. I'm sure we all will.
Don't say that.
There's other ones.
Stay positive. Believe in yourself.
So basically 2 months of foundation.
That's perfect. That's all I care. It's all together. It's on your slides.
Okay. Ready? Thank you. Okay.
Doesn't mean like what she's asking. What I have is in I need to What I need to
it's gonna affect her ability. They say that if you have
We have some questions for you. We can do it at lunch. Do you remember? Do you remember what you explained to me about the math? Well, I forgot. Don't you? Don't you do the percentage at the end?
No,
Or
you do
you
it first.
before?
So you do the percentage after you do morphine first percent.
So, Alex, my question is, whatever drug she gives us, she always has to get
Oxy to hydrocodone or oxy morphine hydrocodone. You only want morphine first. And then you do percentage. I mean, not percentage. But if she can tell you whether she wants 25 or 50, so it's going to be old drug, you're going to be told to go to morphine. Do the percentage, and then go to your new drug. It's fine. We'll do some practice.
Alright, we're back. Okay, good questions got asked during the break, right? And some questions were, do you always get x-rays for this? Somebody told me that Mr. Wright, God bless him, right? I miss him. He's fishing, which I'm jealous of, every day, all the time. So, but he showed you a video, right, of some creepy person trying to give somebody a lollipop or something, right? And there was a suspicion that it was a nursemaid's elbow, not a handmaiden elbow, right? And then the provider did the reduction, and then handed the patient the lollipop, right? And then all was well, all felt right as rain, all that, right? Did they get x-rays? No. Okay, so do we commonly get x-rays? To be honest with you, if the mechanism's there, patient's sitting in this position, right? And the story is there, and they're tender there, and they're disorder of vascular intact, because you did your radial ulnar median, rock paper scissors, all that stuff, right? And you do the reduction technique, and you feel that pop, and now they're moving the arm. Are we good? Yes, we're good, right? As a concept, though, we try to teach you to always think about getting x-rays, because I'll tell you this, what if you do all that, and you're not able to feel that pop, and the patient doesn't want to use their arm at any point after you do these reduction maneuvers, right? Because that's what you're doing, correct? You're doing reduction maneuvers, okay? Do you then transition to x-rays 100% of the time? Yes, because you may be dealing with something that's more complicated. And do you then, let's say you're sitting in a primary care clinic, at that point, do you then send them to somewhere else, potentially, so they can consult ortho if it's not available in your facility? Yes, right? So these are decisions in management. Make sense? Okay, but as a general rule, we try to implore you guys to get x-rays on everybody, right? Because then, going forward in practice, you'll start realizing, well, he said it's common in 5-year-olds, right? So if I see this presentation, I know it's common. This is the common presentation. So you're gonna tailor your practice style to the way patients present, and not just some algorithmic chart in a book that I'm teaching you on a day like today. Correct? Okay. Make sense? All right. All right. Look at the toenail polish, right? And this patient's got a lot going on. So. All right. But if you get the x-rays and you see this, and you're unable to get the reduction, don't keep trying. That is a dislocation. That's the reason I tell you this. You will not get this potentially just doing that, the pronation with the pressure at the radial head and deflection if you need to. You will not get that back in that way. But, you know, you just won't, okay? Maybe, but for the most part, no, okay? Maybe require more, okay? So we already talked about this concept too. Say you get an x-ray of the elbow and you see this. Do you also want to get x-rays of the wrist? For sure, 100%, okay? But we'll get into that when we talk about upper extremity, or more upper extremity injuries, and specifically fractures and walk forward. Okay, any more questions? Really good questions, guys. All right, Mr. Wright was trying to help you. I get it. All right, he used lollipops, apparently. That's his creepy maneuver. So, all right, so little leaguer's elbow. Okay, you guys already heard me say this. I hate this term. Because little leaguer's elbow denotes that it's only in certain patients, right? But it's a catch-all phrase for a bunch of different conditions, all right? So I'm telling you right now, sir, as you drink your premier protein, that you should make a note that I am recommending to all of you guys, right, that you go and read the textbook when it comes to little leaguer's elbow, okay? As you drink your premier protein next week, you need to go and read the textbook, read the highlighted readings. That's what I'm talking about if you don't want to buy a book or you're too lazy to log in, right? All that highlighted reading stuff is available to you at no charge and no muss, no fuss. Okay, because little leaguer's elbow is confusing. Okay, it is. It just is, right? Every time I'm going to lecture on this, I go back and review, right? Because I'm like, I want to make sure I don't say something wrong, because some of you guys only listen to me, right? Now, nobody does that, right? And they only read their slides, right? So making sure I don't say anything wrong. Okay, so little leaguer's elbow, by definition, is more of a phrase than a definition, because it includes a bunch of different conditions and pathologies that can cross over, but that, for the most part, in classification, have a basis in ages, okay? So, traction hypophysitis to the medial epicondyle. Let's break it down, guys. As you're reading through this, right, you're looking at this slide, you need to decide for yourself, are we talking about the medial side or the lateral side? Because if you think about it in those terms, I hope that it will make more sense, right? Are the top two medial-sided? Yes. And so are the last 3 and 4 lateral-sided? Yes, because you guys know your anatomy, correct? You know where the capitellum is. It's on the lateral side, correct? So as you're studying, this is how you're studying it. You're classifying it not only based on the definitions individually of each condition, but also, are we talking medial or lateral? That way you don't get them twisted, as my son would say. Don't get it twisted, Dad, right? Don't get it confused, okay? All right? That way you're on track. Traction hypophysitis to the medial epicondyle, right? So traction hypophysitis is basically what they're talking about is when you're throwing a baseball, right? I shouldn't use myself as an example. When you throw a baseball, you take your elbow and you put it in extension, you put it in flexion, and when you throw and release, you put it in traction, correct? So is that what we're talking about here? That's what we're talking about here. It's a traction hypophysitis. So if it's hypophysitis, you guys remember from anatomy and physiology, they were talking about skeletally immature patients, correct? Yes. So we're talking about pediatric patients, okay? Getting away from that term little leaguers. We're just talking about pediatric patients. But specifically when we're talking about fragmentation, that's because of over time, right, that continued traction is causing fragmentation of what? The medial epicondyle, correct? So that's what you're going to see on an x-ray potentially. If it goes on, if that growth plate there, right, on the medial side, the medial epicondyle, goes on to fuse, I won't make you guys memorize the chart of when things fuse in the elbow, right? But if you do, it'll be like, oh, I get this, right? But there's an acronym for that too. But if it goes on to be older and that growth plate is now fused, you won't get necessarily as much as that fragmentation because now it's a solid unit, correct? So now you'll get an avulsion. So now that growth plate is closed, so if it's going to pull bone off, not just fragmentation. That's what you're talking about there. So basically, if I had to sum it up, right, if you remember nothing else, the first line where it says fragmentation 8 to 12 years old gets more to the traction, and maybe more so when they're younger, they have open growth plates. And the avulsion, 12 to 14, means now their growth plates are closed. So if it's going to be a pulling, it's usually going to cause an avulsion of that bone, and not just little pieces, not just little chiclets. Are we good with that definition? Okay. So ulnar collateral ligament injury, well, we just talked about that. But we talked about it with adults, right? But in this case, it's throwing patients that throw, that are pediatric patients, correct? So again, is that going to be needle-sided? Are you going to potentially have some pain with valgus stress testing? Yes. So that one is specifically talking about the ulnar-collateral ligament, or the medial ulnar-collateral ligament, or the medial collateral ligament of the elbow, right? That's what they're talking about. That's all they're talking about, right? No fragmentation, none of that stuff. You're talking about a tear of the UCL itself, okay? So moving on to number 3, then now we go from medial to lateral, correct? We just said that, okay? So the way I want to talk about 3 and 4 is the capitellum is on the lateral side, right? What does OCD stand for? It's not the condition that some of you guys have. All right. Right. In this case, it's osteochondritis dissecans, right? Don't reveal your HIPAA violations. Don't want to know about it, right? But capitellar OCD is osteochondritis dissecans. Osteochondritis dissecans. If you've never heard that term before, you need to know it. Because when we start talking about lower extremity stuff, then that rears its head again. Okay? So capitellar OCD is literally, because of that traction, because of that baseball-type motion, right? Because this is all under little leaguers, right? There is a separation of the articular side and the bony side, okay? So subchondral. So you get a separation of that, okay? And that's why when I talked to you guys about this before, when we start talking about capitellar OCD, what's the age group for that? 12. 12, right? So are the growth plates closed? Yes. Yes, potentially yes. Okay? So that's what we're talking about here, right? So that's capitellar OCD. That is a separation between the cartilage side and the subchondral bony side. Okay? Make sense? I hope. Don't worry, when you go back and read it, hopefully it makes more sense. So Panner disease is a more specific and very precise definition. This one actually has a pretty good definition. Because Panner disease is what age group? Less than 12 years old. Okay? So when you're studying for this block, and you're studying Panner disease versus capitellar OCD, focus in on this age distribution. Okay? It says less than 12. It's actually 5 to 10. We won't get into that. It's because that's saying less than 12 is still not incorrect. But the point being is that this is a developmental issue, meaning the growth plates, right, as the child is developing, gets fragmentation, okay, and flattening. Okay, so when you get the X-ray of Panner disease, it'll be a child who's like 10 years old, okay, who has fragmentation or flattening at that growth plate. You see what makes that different than capitellar osteochondritis dissecans? Not just the age, but the way that the pathology progresses. Okay? Are they both due to potentially, again, overuse, throwing motion type stuff? Yes, but Panner disease is a very specific one, right? So when you learn those, make sure you understand that Panner disease has a very specific distribution in the way it looks. Okay? When it looks as far as like radiographic findings, etc. Is anybody confused yet? It's okay. Yes? Okay, thank you for your honesty. I will agree that, again, if I were you guys, I would read the text for this, okay? I'm not telling you anything wrong, I promise. I'm explaining to you from an anatomy standpoint, right? From a growth and development standpoint, and maybe you just don't think in those terms yet, okay? I get that, okay? But nothing I'm telling you is wrong, okay? So from a standpoint of Panner disease, if it's just a developmental issue, do you think for the most part, if you just tell the kid to chill, as my kid would say, right, and just be, not do throwing motions, avoid certain activities, that they're going to continue to grow and develop as normal? Yes, they will. So that's the rule for Panner disease. Panner disease tends to be a more benign condition, but when you see the word capitellar OCD, is this an older patient? Yes, it is, right? So at that point, since they're not growing anymore, if they go on to get some kind of disruption, right, do you think that could be more long-lasting? Yes, and it could be more detrimental to the range of motion and activity level as they get older. So capital OCD has some surgical considerations and some concerns, okay? All right, symptoms. Well, pain with overhead throwing. And again, you start talking about chronic or acute. Is this something that just happened? Usually they say it's a history, kind of comes and goes, right? Now, on the off season, they still have it a little bit for the first couple of weeks post-season, but then it goes away, for example. But then as soon as the season starts again, or as soon as what? They increase their pitch count, the number of innings pitched per week, etc., then they start having pain. That's the clinical history. That's why it's important to get a history. Is that part of the T in OPQRST? Yes. Timing, temporal factors. Okay. So again, you're supposed to be asking these questions anyways, right? Some people play year-round, so maybe they have pain all year. Not useful information, but at the same time, just understand. Okay. Use of breaking ball before maturity. I don't know what a breaking ball is. Okay. But if you want to memorize that, fine. Okay. I don't know. I guess there's a correlation. Apparently, with a breaking ball, you got to do more heroic motion, right? Does anybody know what a breaking ball is?
Curveball.
Curveball? Okay, thank you. I know what that is. Okay, so breaking ball, curveball, there you go. Hey, see, I learned something too. So, but the important thing to take away from this, you see how this is trying to describe to you where the tensile forces are in this picture? Okay, so this is actually a really good picture. When you take the slide before, let's say, and you lay it down with this, and you're like, where is this pathology occurring and why is it occurring? Okay, so this is a good picture because they're all throwing, right? This is all under one big catch-all of little leaguer's elbow, okay? All right, so is that a valgus stress test? Yes. So if you had to describe it, you would look at this picture and you would be able to describe this picture, okay? You should be able to do that by next Friday, okay? Because tenderness of palpation is the most common finding, sure, not as helpful. But loss of elbow extension is common, okay? So why is that? We already talked about UCL injuries and how they may get that loss of extension, right? So you may see that as well. So if you're thinking loss of terminal extension, you want to do your stress testing, correct? So if you do your stress testing, okay, that if you're suspecting UCL injuries, you can grade it based on that, right? And if you're suspecting OCD, remember I told you OCD can be a spectrum, right? Right? And there's a lot of surgical considerations. But if you have instability and you have an OCD, then okay, good to go. I think we may need some surgical console here. And Panner disease, again, in Panner disease, is, if you say a 14-year-old has Panner disease, I have failed you. 14-year-olds don't have Panner disease, right? I told you, less than 12, correct? Okay, but you still want to do all the physical exam stuff, correct? But if they don't chill, even though it's a benign condition, right? You guys have seen, we all know the Tiger Woods of the world, right? The parents are like, you got to improve, increase your pitch count. So it's like an 8-year-old whose parents are just on fire. Those parents that the coaches have to throw off the field every Saturday or Sunday because they're just too intense, right? So you'll see that sometimes. That's all that's leading towards. Okay, good to go? All right, radiographs establish most diagnosis. Did I use terms like avulsion, fragmentation, flattening? I did use those terms, right? So if you're going to get a radiographic finding, then you lay those terms down that I described to you and put them in the proper categories. And you say, okay, which one has flattening? Which one has flattening with fragmentation? Which one has separation, right? So that's why a lot of times the actual x-rays can help you make a diagnosis, okay? With the exception of maybe a UCL injury, because then you may have instability and you got to get an MRI, okay? So MRIs, it says here, often necessary to confirm OCD versus Panner versus UCL. So again, if there's a mixed clinical picture and you're concerned about it, you're going to get an MRI to confirm. Okay? Focusing on the word confirm, because again, this doesn't replace anything. Okay? You still got to get a good physical exam, got to get a good history. Any questions about that? I'm not going to give you this picture here and say, is that a normal growth plate? Who thinks I'm going to do that? I'm really not going to do that. Yeah, I'm not, right? Because that's like that's something else. But anyways, the point being, when I look at that, I can tell you that's abnormal. Okay, why? Because it looks like there's some inflammation there. Would you agree that this white stripe here, that looks like almost sclerosis? Does that look like sclerosis to you guys?
A little bit.
Does it? Yeah, it's a white stripe. Isn't that the definition of sclerosis? Where it looks like hyper white, right, from an area of stress? okay, or degeneration in the case of osteoarthritis, right? So it just doesn't look right to me. It looks like there's increased tension there potentially, right? So, but I won't ask you those questions unless you want me to. Let me know. All right, so elbow treatment. So when we're talking about these conditions, you're just gonna have to learn them, lay them out, hit me on test review day. I'll give you some ways. If by then you don't get it, I'll give you some stuff. So you'll be like, okay, you remember only this, know this, right? I won't give you to today though because I want you to read, right? So non-operative, what's the don't do sign, right? Don't throw, okay? Burn that into your mind. These are all throwing related, right? So the treatment is don't throw, right? Unless you see significant separation in OCD, for example, of the capitellum, because then you're like, even if you don't throw, that significant separation requires surgery, okay? So how long are they not going to throw? It says here 3 to 6 months. How long is a baseball season? I have no idea, okay? But it's at least 3 months, right? So they're out for the entire freaking season, depending on how bad it is, right? If they have Painter disease, it's a growth and development issue. Do you take them out for the entire season? Yes. If you're a good clinician, you do, right? Because you want them to continue to grow and develop as well. See examples of application. That's how you apply this knowledge. Okay? You're like 3 to 6. How am I supposed to remember that? So did I not tell you that OCD can be more significant? So that may be a restriction of upwards of 12 months. Hopefully the way I'm teaching you guys, you remember these things and focus and reinforce. Okay? Operative, occasional, sure. If you think it's do kids normally get like big, significant isolated UCL injuries? Not normally, but again, the Tiger Wood concept out there, who knows? If their pitch count is 800, I think that's high. Right? That's high, right? So maybe they're predisposed. But surgery is not necessarily always indicated. You just got to get a sense of where they're at the disease process. Are loose bodies ever good? Are floating chiplets in and around the elbow ever good? Yeah. Right? But if it's just a little bit of fragmentation, maybe we'll say, that'll heal up, they'll grow through it. If it's bigger loose bodies, is there consideration, for going in there and going after them? Sure. But only if it affects range of motion. Okay? So not common. Still not common. Okay? Good to go? All right, what did we talk about? All this stuff. Lateral epicondylitis, medial epicondylitis. Understand which is which. Lateral epicondylitis, medial epicondylitis, English. One is tested with resistant extension of the wrist or hand, right? At the wrist or hand. And one is tested with resistant flexion of the wrist or hand. Hopefully you guys understand that. Reinforce your anatomy. For lateral epicondylitis, very common to do the full gamut and plus or minus corticosteroid injection, right? So for medial epicondylitis, you can do the full gamut, but do you ever do corticosteroid injections for medial epicondylitis? Only if you want to get sued, okay? So don't do it, right? So I will tell you this. I talk about steroid injections, and then no one's asked me. I was waiting for it. They're like, well, when do you give them a steroid injection for lateral epicondylitis? Let's pick on somebody different. If Mr. Rudolph comes to me, right, with lateral epicondylitis, I'll probably just say you're weak, sir, and you need to just push through it, and you get nothing, right? But no, seriously, do you think if he comes to me and he has 5 out of 10 pain, but he's like, I can still do things, it just hurts when I do certain activities, do you think it's reasonable to say, don't do those activities, give him the activity restrictions, and send him to physical therapy and see if he improves? I think that's reasonable, right? So would I do an injection for him at that time? Probably not, right? But say he comes to me and it's 9 out of 10, or Nigel pain. Everybody know what Nigel pain is? 11 out of 10? Nobody likes, okay. So say they have 10 out of 10 pain, because every patient has 10 out of 10 pain. And you send them to physical therapy. Do you think if Mr. Rudolph tells me that he has 10 out of 10 pain, and I send him to physical therapy, then physical therapy is going to be able to do anything with him? No, right? And more importantly, again, you're sending them there to do nothing, right? So sometimes I'll consider depending on their pain level, I will do an injection right away. But if you do injections for everybody, think about this. If you do injections for everybody, do you think anybody's going to go to physical therapy at that point? No, because they're going to feel better. They're going to be like, I feel like $1 million, man. I'm good. I'm going back to IPAP and continue crushing it, right? But the thing about it is that, again, you understand that is short-lived, right? Corticosteroid injections are not permanent. They wear off, right? It's an anti-inflammatory. It's just steroidal, correct? So then the patient comes back to you and you say, well, I did the steroid injection, I sent you physical therapy, you never went. Now your pain is back because you're still doing the same activities, right? So then, do you give them another steroid injection? God help you. That's what you call the definition of insanity, right? Doing the same thing over and over and expecting a different result. So be judicious in your injections, okay? Olecranon bursitis, did I scare you enough with my story about the zipper arm? Okay, when I said zipper arm, right, I meant like, not like superficial. You can see stuff. It's open, it's deep, right? So I'm trying to give you an example of why you don't go poke it. And as I said, my preceptor told me, don't go where you're not invited. You are not invited into the elbow joint when a patient has olecranon bursitis. You have no invitation. You have no right to go there, as I'm saying in this analogy, okay? So if you know that you can do a proper drainage, right? Plus or minus steroids, fine, it's out there. I don't do it, all right? But say you can do a proper drainage, either for diagnostic or therapeutic or both purposes, good for you. If you don't know what you're doing, maybe send it, okay? Good to go? All right, and what I would stress about olecranon bursitis is make sure that you are, with olecranon bursitis, make sure you are reading those, that guideline that tells you how to treat patients, right? Because there are very specific guidelines about if it's small, right, or if it's larger, right, if they have a certain amount of pain. So the way I would study that is I would study it just like that. For this patient with these symptoms, I would treat it like this. You know, when do you use compression? When do you use, you know, when should you be concerned about infection? Open-ended question. Mr. Rogers, what do you think? Rogers Paulus.
It's probably you know the full name.
Red, hot, swollen joint is what I heard. Right? Joint. Is the bursa a joint? No. They may have redness and a little bit of warmth at the elbow, right, the tip of the elbow, but make sure that they don't have red, hot, swollen joint. Okay, good to go? Nerve compression syndromes. All right, I think I hit that decently. So make sure with nerve compression syndromes, you understand the distributions, you understand where that tenderness may be, and what kind of complaints the patient may have. Understand the importance of PMG and CS in those circumstances as well. Okay, distal biceps tendon rupture, reverse Popeye deformity. For the most part, surgery is a rule, and usually within 2 weeks, get an MRI. Okay, ulnar ligament tear of the elbow. That's, again, there's the thumb too, right? We're talking about the elbow. So when it comes to UCL tears, these more so in that discussion is about adults. Make sure you get a good exam compared to the contralateral side. Is an MRI helpful in confirming it? The answer is yes, right? Nursemaid's elbow, not handmaiden's elbow. Do not do that, right? Nursemaid's elbow, so nursemaid's elbow is just a catch-all. But it doesn't have to be just a traction of the arm, the mom pulling the kid in the playground. It may be just traction from, again, jumping, grabbing onto something, and then they pull on their arm. Okay, but the mechanism is there, okay? Do you guys, if you guys had to describe the reduction technique today to me, could you do it? Well, you stumble through it. Yes. Yes. As most things in life, right? Not you specifically, but me. Yeah. But make sure you can describe that reduction technique, right? Okay, because that's important to know. Because do you think maybe a patient, sometime in phase 2, that a preceptor might set you up? Have I done this before? I don't know. Maybe I have. The jury's out. So have I set up a P2 student and said, I know what's in curtain 5, right? And I said, let me see what happens, right? So then you start the social experiment, okay? And you're like, hey, Ufi, I want you to go see the patient in curtain 5, right? And tell me what you think, right? He should be able to walk in the room and be like, okay, I think it's a nursemaid's elbow, and then, again, do the exam. And do you think if you're confident, especially towards the end of the P2 year, right, phase 2 year, that you can just go ahead and see if you can get a reduction?
Sure.
Sure, right? It's reasonable, right? So I'm waiting to see, right? Because usually I won't pull this on if you're new. If you've been with me for 5 weeks, though, you're only with me for 6. You're with me for 5. I want to see if you're gonna, if you A, come to me and say, I thought about doing this. I'll say, oh, you did? Well, why don't you go do it and then let me know? Or you did it, came back and said, now the patient has full range of motion. I think the discharge is this, you know, et cetera. And then I'm like, yes. Do you think your preceptor eval gets filled out differently? It does. Okay. All right, I'm fair. But whatever. Well, you see what I'm getting at. You got to start getting to that point in your careers, guys, as students now, but as budding clinicians next year, where you're not only talking about all this book knowledge you got, but you know what to do, right? The first time maybe you got asked, what do you want to do, sir, was in junior clin corps, right? They're like, what is your treatment plan? You're like, who, me? Right? Like, I have to come up with a treatment plan? It's like, what do you think all this is for? Right? So that's the thing, you gotta make that transition. Make sense? All right, all joking aside. Little leaguer's elbow, I mean, I could spend months on that and still not hit it, okay? So little leaguer's elbow, trying to focus, get away from that, the little league part of it, and just say it's all throwing motion, and then focus in on the age distributions and whether it's medial and lateral, okay? Good to go? I do want to keep going. You guys cool with that? Okay, we just got to make a little bit of traction in case I got to get on a bird and disappear, okay? Animal bites, okay? So animal bites covers all animals, okay? Whether it's dogs, cats, I don't know, chameleons, whatever kind of animals you have at home. Oh, camels? Yes. That's weird. But when you're talking about animal bites, so the most common thing, thank you, I appreciate that, is dog bites. Dog bites represent 90% of animal bites, okay? There you go. There's your epidemiology. You're welcome, right? So second most common is what? Cats. My math is 95%. Does that mean there's 5% of other things? Sure. But again, the two I talk about is dog and cat. When I want to get clear, the reason that allegedly I changed this slide to put them side by side is that dog bites, do dogs grab on and tear? They do. Do cats kind of bite and puncture? They do. So a lot of times with dog bites, right, you can treat it and you can see improvement, right? But when it comes to cat bites, we talk about hypodermic deep punctures. Okay, so if you think about that concept of a hypodermic needle, when you go to get your flu shot and they stick it in your shoulder, right, you're like, ooh, that was deep. That's the same thing that's happening with a cat. Do the cats and dogs normally bite hands? Yes. Do your hands have joints? Do your hands have flexor tendon sheaths? Yes. Okay, so that's what I'm saying. So cat bites can be more concerning though. And that's indicated by the bottom there. The infection risk in a cat bite is 30 to 50%. So I will tell you this, every cat bite you call me about from now until we all go to Narnia, right? I will think it's infected until I've examined that patient. That's just how I roll, okay? Because cat bites, for the most part, the rule is you'll get some level of infection, deep infection. The question becomes, where is it not? Okay, so 30 to 50% cat bites, okay, is the infection risk. Dog bites, less risk, more tearing and taking away than puncture, okay? You guys know this at the bottom already, right? I added this just to reinforce, okay? But you guys know that you have to ask the patient. You guys already talked about rabies vaccines? Yes, okay, all right, and rabies. All right, so you know that you have to ask every patient when it comes to dog bites, cat bites, right? Whether or not, bless you, they have up-to-date immunizations, right? Because if they don't, you got to give it to them, right? Depending on their status, okay? So that's all that's getting at the bottom. I won't go through that too much. So this is a point that confuses people, but I will tell you this. When it comes to cat and dog bites, again, you just have to know the common stuff, right? And I'll tell you what those are. I've highlighted what they are. But just understand that when you look at this up here, does that look like a cat or a dog bite, guys? Okay, this looks like a dog bite, right? I know you're recording this side, right? So this looks like a dog bite. I would agree, okay? Or a human bite. Humans are nasty, right? But down here, what does that look like? That looks like a puncture wound, right? So that's more of a cat. Maybe it's a snake, but we won't go there. But that looks more like a cat bite, right? So when you're talking about this, right, do you have all kinds of bacteria that live on your skin? Yes. Do animals have all kinds of bacteria that live in their mouth? Yes. So as a rule, even though we talk about certain common things that are common in those kind of animals, but as a rule, the bite is microbial. Polymicrobial, bunch of bugs, right? If you grow them out, it's going to be a bunch of bugs. But what you shouldn't find, right, in, let's say, a snake bite is Pasteurella multicida, because that's associated with which kind of bites? Okay, dog and cat bites in this case. Don't start quoting literature. Okay, I don't disagree with the mammal, but I'm just saying in this case, dog and cat. Okay, although the most common organisms are which ones again? Staph and gas. I know that sounds funny, but that's how I remember it. Staph and gas, right? I'm not smart enough to remember everything anymore. I just remember a certain way. Or if you want to call it alpha hemolytic streptococci, but basically it's a strep, okay? So staph and strep, okay? So again, you don't get this concept confused. I see this every semester. Patients like, whoa, didn't you say the most common was staph? Read the question. What is the question asking you? Right? Because what is unique, right? I have a gentleman in the back who probably knows more about this than I do. So, but at the same time, you know, Pasteurella multicida, you shouldn't find it in certain cultures for certain bites. Okay? So that's something that's unique to dogs and cats. Are we good with this slide? Notice how I slowed down. What do you think a high-miss question is every single freaking semester? All right? Because you don't read the question. All right? Anyways, so what's always a concern for infection? Does that look like does that look nasty? That looks bad. It looks like almost like a battery burn. Have you ever seen a battery burn? That's what that looks like, right? This was originally a dog or a cat bite. Okay? Does this look like it's pus under pressure? Okay? Yes. That looks angry. It looks like there's a lot of swelling in there, right? So that is something that you may see. Okay? I will tell you that the pitfall for cat and dog bites is, and specifically in cat bites, is that you look at it and say, I'm going to wash it out. Bless you. Open. So you look at it and you say, I'm going to wash it out. I'm going to suture it tight, right? Because I want to make those ends neat. I'm a prior medic, and I'm going to make this thing look beautiful. I'm a budding plastic surgery PA, right? That's the wrong answer. Because if you take something that was open, right, and loose and draining, all of that stuff's draining out and stuff, and now you close it tight, you're creating a pocket for pus to develop and therefore become pus under pressure?
Yeah.
Yes, right? That's what you're creating. So, and are we talking about dog bites? Yes, right? Because cat bites are usually those puncture holes, right? That's what's being shown at the bottom there. Okay, so that'll come up again soon. Do you want to get a neurologic assessment? Yes. Do you want to do a complete span and scan of the extremity? Does anybody see that? What's this called here? Phlebitis? What is it? Lymphangitis. Yes, not phlebitis. Lymphangitis. Thank you, sir. Yes. Is that an indication of also called high five? Also a indication that there could be spreading infection? Yes. So again, you're looking for the entire clinical picture. Okay, good to go. Unprovoked attack. Okay, this gets back to that concept. I'll talk about it real quick. Is it your dog, sir? Is it your dog, ma'am? Ma'am? Sorry, you're looking at me. Ma'am, is it your dog? No, it's someone else's dog? Do we know the dog's vaccination status? Like, you're going to become a dog hunter, a dog sleuth, right? Not really. But you just want to get the information if it's available. If it's a stray dog, are you usually going to lean towards giving the rabies? What's the incidence of rabies in the United States? Not high. Certain areas, right? But if you're stationed overseas, especially, you're always going to give it. But are you going to update their tetanus status? Probably. I don't know if I want to come see you. I want my tetanus updated. Okay? Yes, the answer is yes. If they're due. Okay? All right? It just depends on which one they give. So tetanus and the overall vaccination status is what you want to know. Okay? All right, good to go. All right, physical exam, red streaks, lymphangitis. Okay, good job. And I think you just read ahead. Yeah. But anyways, so if you see purulent drainage, right, you can see that within the first couple hours. Should it be purulent? Not the other word, right? Not the 1, 2, 3, not the 5-letter word. Okay, don't say that word. It's not a clinical word. Purulent. Okay, may not be present initially, especially if you do a nice washy, right? So, do you think that hypodermic needles poke that can come back as early as 4 to 6 hours later? Flash it. as early as 4 to 6 hours later, and now all of a sudden it looks more like starting to head in this direction, yes, cat bites can progress quickly. Okay, so you have to, again, I already told you 50% of them are infected, right? You need to be, you have a strong suspicion. And should you see those patients back sooner? Yes, right? But at time of presentation, you're just going to get a sense of what structures are involved. Okay, I put that in bold gold, right? So I think you need to know this because we're going to talk about flexor tendon injuries tomorrow. Okay, if I'm here. Either way, we'll talk about it tomorrow. But wound depth and tendon and nerve or joint involvement. Okay, if it's anywhere near a joint in the hand, especially, do you think I'm going to assume it's in the joint? Yes. Okay, that's just how my mind works. We're surgery, we don't fail. Okay, I'm not saying primary care does, but we can't fail, right? So you're going to test sensation, you're going to test tendon function. We'll talk about those tendon function testing tomorrow. Have you guys been through a little bit of this, isolating the different joints of the hand, the fingers? No? Okay, we'll go through that, okay? All right, good to go. All right, so are you going to get x-rays? Yes. What is that right there? That looks like a canine tooth, doesn't it? Or maybe it's someone in this classroom's tooth, who knows, right? But at the same time, you want to get x-rays because you're looking for foreign bodies to include a tooth. Okay? That includes every foreign body possible. You're not just looking for like gravel, spruce leaves, whatever, right? But you're also looking for fractures, okay? By definition, if there is a fracture and there is an open dog bite, is that an open fracture? Did we already talk about how all open fractures go to the operating room? Okay, good to go. Gas in the soft tissues, you guys know that if there's violation of the planes in the soft tissues, that they can form gas as a result of disease process. So we'll look for that, okay? Especially if there's a concern for it getting into the joint, okay? All right, lab studies, here we go back to the labs, right? I'm not gonna spend too much time on this, but didn't I tell you that, right, I urged you for any patient you're concerned about infection to get baseline labs, right? So didn't I just tell you as well that if a patient has a cat bite, then they usually present pretty quickly if it takes off in a certain direction? So wouldn't it be helpful, the answer is yes. So wouldn't it be helpful to have a set of baseline labs so you can get a repeat draw and see how bad it's gotten from a lab standpoint? You see the value in it, I hope, right? So don't be that person when I call you and say, oh, I got bit by a dog, his flexor tendon's out, all this craziness. And I'm like, okay, cool. Did you get x-rays? Nope. Did you get labs? Nope. Okay. I'm sorry, I can't hear you. You're breaking up. All right. After you get the labs and x-rays. Right? So you see what I'm getting at, right? Get them. So especially if you're concerned about progression. I would tell you when it comes to cat bites, I get labs for all of them. I told you already, 50%, right? Infected as a rule. Okay. Wound swab, we know the difference between a culture and a wound swab, right? Like a biopsy, culture, wound swab, we know the differences between these, right? So are these wound swabs going to be like a big gaping hole that you're putting a Q-tip looking thing into yes, that's what we're talking about. But when you do this, are you expecting it to be polymicrobial? Yes. Okay, the answer is yes. But you're going to get a gram stain culture, right? So why do we get a gram stain culture? Again, that's to identify the bug so we can kill it. Okay? What might you see in a cat or dog bite? What bacteria? Multicida, right? Okay, there you go. They might expect to see that. Will you see it 100% of the time? According to your textbook, yes. Right. Maybe problematic if superficial. Again, if it's not that deep, good luck with the cultures, right? But if you got a big, gaping, deep hole, right? And I'll put those, remember I told you guys about that knee injury I had? Where somebody jumped off the seawall and had those two big gaping holes and I stuck my finger all the way up in there to see if I could put my finger into the joint? I'll show you that, right? That's an example of an area where you definitely want to culture it because you can get a good culture. You know, if you've hit brain matter, then you've gone too far, especially if it's the knee. But adverse outcomes of disease, right? This is all the bad stuff. I'm not going to read these to you. If they get rabies, game over. If they get tetanus, game over. You guys see the picture of tetanus, right? End-stage tetanus already. The guy all like, totally tense and just his back breaks his back and all that. Game over. And you don't want to end up like Cujo, okay? So make sure you check immunization status, okay? If it's the bottom line there, what this gets weak to is that you do improper treatment, or say that they have it's a dog bite, right? Again, dogs grab on and kind of shake their head and tear, right? If they tear a nerve, we hope that function comes back, but especially if it's more towards the tip, right? No jokes. Just towards the tip of the fingers, maybe you'll get that sensation back, but the patient will say, well, I'm just more sensitive to cold and heat after that injury. But they got function, right? In orthopedics, are we more concerned about form or function? Function. It looks bad, not you, sir. It looks bad, but it works. Okay? All right, so unoperative, again, all that stuff. This, focus in on. You guys know the antibiotics now, right? Am I still going to ask you antibiotics? No. But it may say antibiotics. That's fair game. But I won't ask you dosages, routes, and all that, because you still don't know. Okay? Joking, sort of. All right? But the rule here, and I should put this in red, actually, or allegedly put it in red, right? You never close the wounds tight. I will show you those pictures, right? Of way I close and you're like, sure, that looks terrible. It does look terrible if you're a plastic surgeon. Well, I was trying to prevent infection, pockets of pus, right? So you want to loosely approximate any open wounds. You want to get it back to a level where it looks like it's supposed to look like, right? Don't leave it looking terrible, right? But as long as you get it to a point where it looks like a thumb again, or it looks like an index finger again, you just don't want to close it tight because then you're creating a pocket of pus potential. A lot of P's. Okay? There's active infection at the bottom there. Does it say IV? So again, when you study for pants especially, anytime it says IV, that means it's not outpatient, correct? Okay. All right. Get that concept down. You see the kind of, this is a specific incision, by the way, that we do. So let's think about this. So if a flexor tendon is going outwards, right? Do you want to do a complete transverse incision? No, because then you sever the ligament, right, potentially. So you do kind of this zipper look, right, this Z look. Okay, there's different techniques of doing it. And that's all they're showing there. Okay, after you do surgery, does that look like it's closed up pretty tight? Yes, but you've done surgery. Does that make sense? Don't trip that, right? Don't get that confused, right? Because this is after surgery, okay? This is after all the badness has been washed out, okay? All right. You guys see this here? That doesn't look close to me, does it? All right. So all wounds heal eventually. All bleeding stops eventually. Right? This doesn't look good. Right? It doesn't look well approximated. The edges don't meet. Right? All infections end. All bleeding stops. It's just whether the patient's still alive. Right? So in this case, this could be a sign that there's a chronic infection because it just doesn't want to close. Okay? And if you get pus under pressure, do you think it'll want to open up again? Yeah, that pressure will cause those wounds or those incisions that you make to try to wash things out to open up. And that's what it's showing you there, okay? What's that called? Dehiscence. You guys have heard that term, right? Where the wound dehisces, it opens back up. Those edges, those approximations become non-approximated. Okay, we got 5 minutes. Okay, red flags. Okay, you got a dog bite, you got a cat bite, cool. You've done the antibiotics, you've treated them, you're gonna see them back, high five, right? But if there's a tendon involvement, are you still going to refer that patient? Absolutely 100%. And that's sooner than later, because again, is it easier to grab a tendon and put it where it's supposed to be before it retracts and goes somewhere it's not supposed to be? Yes. That's what I'll tell you for today, because we haven't talked about that yet. When we get to that part, I'll go expand a little bit more on that. Joint capsule violation, anytime it crosses a joint, that is an open fracture. Okay? That is a concern. If they get a joint infection, that's called septic arthritis, right? Is that one of the only true surgical emergencies we have in orthopedics? 100%, okay? And underlying fracture, because then it becomes an open fracture. That's kind of intuitive, I hope, at this point. So, all right, I don't want to burn through this. Any questions for today? Okay, do you guys understand how to study for cat and dog bites? There's more to it than this, right? But pants, we tried to teach you guys like the stuff that pants, not that we're teaching the test, but the stuff that they think is important.